Hello and welcome to Community Matters, a podcast from the Canadian Association of Community Health Centres. I'm your host, Hilary LeBlanc. On this episode of the podcast, I am joined by Tricia Smith, Executive Director at Radius Community Health and Healing, a community health centre in Edmonton, Alberta. Radius Community Health and Healing was founded in 1979 and is Alberta's first community health centre. The CHC was recently renamed, and some of our listeners may know the centre by its previous name, Boyle McCauley Health Centre. Through primary care and health promotion, Radius works to improve the quality of life and well-being of populations and individuals facing multiple barriers to accessing health services. How are you doing today?
I'm doing great. Thank you.
Awesome. Thank you for being here.
Thanks for having me. This is great.
Of course. Please start off by telling us a bit about Radius Community Health and Healing, its location, the services and programs provided, and the communities and population that you serve.
Sure. So thanks again, Hilary, for having me. And I think as you've mentioned in your intro, Boyle McCauley Health Centre started in 1979. That's when the society was formed. We actually started operating in 1980 and seeing patients. And it's now one of 3 community health centres in Alberta. There's 2 in Calgary. There is another community health center in Edmonton. Their focus is a little bit more housing focused. So our sort of focus of operations is a little bit different. And now, as you've mentioned, changing our name to Radius Community Health and Healing, which was a pretty exciting process. So we're located near the downtown core of Edmonton. So, what a lot of people refer to as inner city. We try not to use the terminology inner city anymore because it isn't always representative of a population. The population is more diverse and spread out in terms of who we serve now. So, but we are located in the downtown core and just outside of sort of the Chinatown area of Edmonton. Our programs and services are really broad, and that's, I think, why we can define ourselves as a community health center and not just a primary healthcare clinic. Our services are primarily primary care. That is a big focus for us. But we also obviously do health promotion focused on harm reduction and using trauma-informed principles. So the nucleus of the organization is really the primary care clinic, as I said, and that includes specialized wound care program that we are contracted to provide through Alberta Health Services, our local health authority. And we have an on-site lab. So right in the building of our clinic, we have DynaLife Lab who occupies space in here, and it's accessible not only to our patients, but also to the community around. People can do blood work, ECGs, and x-rays right in site. We have specially trained lab techs who actually can do both. Most labs don't have that capacity in the community. So that's something that's very unique about us. We have a supervised consumption site in our building, one of 2 in the city. Well, 3, I guess, if you count. There's one in the local hospital as well, but it's only for inpatients. So one of 2 that's accessible to the community that's not hospitalized. We have a nonprofit dental clinic as well that has 8 chairs that operate. We're the only nonprofit dental clinic in Western Canada. I believe there's one in BC. Again, their business model is a little bit different. And we operate on a discount basis. So for individuals who don't have the ability to pay for dental services, don't have insurance coverage, for example, they can get discounts from the Alberta Fee Guide based on their income. So they actually provide tax statements to us to show what their income is, and based on their income level determines their discount level. So that's very, and that is done in partnership with the University of Alberta Faculty of Medicine and Dentistry, because we actually have dental and hygiene students that work there during the school year to provide care. But of course, the students aren't paid, and so we're able to provide those services at a discount. So that's really helpful. We have housing programs as well. So we have a Pathways program, which is focused, it's called an assertive community treatment model. And that model is for individuals who have severe and persistent mental health conditions, often with other complex illnesses, such as addictions, that really complicate their day-to-day lives. And those individuals are supported to live in market housing, but they're supported by a team of multidisciplinary health professionals. So we have a physician, a psychiatrist, nurses, recreational therapists, occupational therapists, addictions and mental health therapists, we have housing workers. So it's a whole team of individuals that really supports that individual to stay housed in market housing. And so sometimes people think the most challenging part is housing individuals. Sometimes it's actually helping them stay housed and providing the right supports in place for that. So we have that program. They stay in market housing, but we support them to stay there. One of our other housing focused programs is called Pregnancy Pathways, and this is unique. Nowhere else in the country is doing a program like this. Harm reduction focused for women who are pregnant and experiencing homelessness. So they come into special space that's, again, it's like a market apartment. It's an apartment that they lease, but it's only for the period of time that they're participating in the program. So they come in while they're pregnant. And we help them, really educate them, make better lifestyle choices in a harm reduction approach. Again, it's not abstinence-based. That's really critical for us. And then once they have baby, we help them take care of baby after the baby is born, give them parenting skills. We work with children's services to navigate custody type of situations. We work with Edmonton Police Service to navigate situations where there might be outstanding warrants. So we can work with the EPS to help get those cleared or deal with them in whatever way makes sense for that woman. And so again, it's a support program and it's also a housing program to help women make better lifestyle choices, hopefully healthier pregnancy and healthier babies. We have a program called Kindred House. It's a program for women and trans women who are involved in the street-based sex trade. And it's a day program really where women can go and frankly just be safe, have a place to land, have a couch to sit on and talk to their friends, get supports, get access to counseling, get access to healthcare, get supplies, whether that be just toiletries or, clean clothes or those types of things. But it's a safe place for them during the day that's off the street. That program's been operating for over 25 years. We have a mobile health clinic that is funded by TELUS Health. And it's just a Mercedes van that's been outfitted in the back like a exam room that you would see in a health clinic, and full of supplies. And we pick specific locations throughout the city where we go and set up and send nurses to provide healthcare. We also have a community response team. This is funded by the City of Edmonton. And so it's a nurse and a client support worker who walk around the area of our building around about a 500-meter radius or so. And it was born out of the opioid poisoning crisis that this population is experiencing, where that team can respond to overdoses, they can engage with clients, provide them referrals, provide them information. Sometimes they can provide harm reduction supplies depending on the circumstances. And it's really just an opportunity to reach out instead of expecting everyone to come in. So we're trying to go to where the people are and provide those supports. We also have a lot of other partnerships that are too numerous to mention, but really I think, as I described the programs, hopefully you've gotten a picture that really this organization is about serving marginalized population that really has difficulty and barriers to accessing healthcare in traditional ways. So, that might be, and we can think about the list of social determinants of health, and really most of our clients are impacted by almost all of those social determinants of health. Some of them just a few, but most of them, it's all of them. So whether that be, unstable housing or lack of housing completely, poverty, so many of them don't have jobs, are trying to live on income support, those types of things. Many of them have, severe mental health conditions or other complex health conditions, addictions. And a lot of that stuff comes with behaviors that sometimes other types of organizations or clinics don't know how to manage or can't manage just based on the type of work that they do and how they approach it. And so our work is really done in teams. And so even our primary care clinic, for example, we have physicians and nurse practitioners that work to full scope, have their own panel of patients that they manage. So our nurse practitioners don't work under physicians, they work to their full scope on their own, but we also have teams that work with them. So licensed practical nurses and medical office assistants, social workers as well, that work together as a team. And so when someone comes in to be seen, the physician isn't the gatekeeper. So they see the most appropriate provider. And if that happens to be the nurse or the MOA, because they just need their blood pressure checked, or they need a medication regularly dispensed or something like that that we can provide, then we just do that. They don't necessarily need to see the physician every time they come in. Our wound care program, as I previously mentioned, is open to the entire community. So it's not just for patients that'll panel to us. So if there's other people that are near our clinic, for example, even if they're not, and they're experiencing homelessness and they have wound care needs that home care can't address because home care needs a place to go, home care needs a home to visit you in, they can come here, and we have nurses that have wound care training that can do some pretty complex wounds here. And also because we have the x-rays available here, we can also do casting if that's needed here. So folks don't have to go to an emergency department and take up an emergency room visit to have a cast put on if it's a simple cast process. We also have in our staff, we have psychiatrists, psychologists. We have a pediatrician that comes in 1 day a week to see children of patients that are paneled here. As I mentioned, we have client support workers, occupational therapists, rec therapists, mental health and addictions specialists, dentists, and a hygienist at our dental clinic as well. And of course, all the admin team that goes with all of those programs. So it's a pretty broad services, pretty robust, and we really, really do focus on the team-based approach, especially in our healthcare piece. So I'll pause.
Yeah, no, that's honestly incredible. I think so many amazing nuggets of things that you said within that full range of everything that you do that really encompasses what a community health center is, that wraparound care, that team approach. Like when I first came onto the job almost two years ago now, it was first explained to me in that way. That maybe sometimes siloed health and just going to one doctor does not get you everything that you need, and you're missing so many other things that actually contribute to the one reason that you're maybe showing up to see a doctor. And it sounds like you are fully, that wraparound care approach is certainly through and through everything that you're doing over at Radius Community Health and Healing, which is my perfect pivot because you mentioned that the renaming process was exciting. So please tell us what sparked the name change from Boyle McCauley Health Centre to Radius Community Health and Healing.
Sure. So the process actually started before I joined the organization. So it's been of a longer journey. We started actually just pre-pandemic, which of course impacted the progress of it. But I think, what was happening in the community is there's another organization that is a social serving organization called Boyle Street Community Services. They do fabulous work, and we do actually serve the same population. Their focus is more on the social side of care versus healthcare. They do have some health services, but not a community health center type of approach. And because of the name is so similar, there was sometimes confusion between those two organizations. And, people thought we were Boyle Street and vice versa. And while our services are for the same population, they're very different. In addition to that, when Boyle McCauley Health Centre first started, it really started as the intention was really to serve a population in a geographic area. So the population that we're serving hasn't really, it's evolved a little bit, but it hasn't changed a whole lot because this is typically where that population, spends most of their time because a lot of the shelters are in this area as well. But I think over the evolution of the organization, the services have evolved to stretch beyond a geography, and that was the primary reason for doing a bit of an investigation, if you will, into the need for a change. And so they did some really good consultations with community, with other partners, with funders, with staff, even with clients who had access services in the past and currently, to just say, is there really a need? Do we need to change our name to reflect, what's changed about our organization? And it came back with a resounding yes. And so we just undertook a process, contracted an agency that does that type of work, and I went under a very robust process of looking into, okay, so who are we and what do we do and how do we reflect that in a name, and do we need to reflect that in a name? What is in a name? It was a very philosophical conversation sometimes, but I got to be part of that process because it was delayed as a result of the pandemic. And when I joined the organization, they were still sort of in the throes of it. So it was a really robust, interesting process. And then where we landed was with Radius Community Health and Healing. And part of that was not only myself, but board members as well, really wanted to reflect in the name what we do in some way. And so that community health center piece just needed to be forefront to really help folks understand what we are as an organization. And then Radius was quite a journey, how we landed there and why. And it really came down to a few different things. One is, well, Radius represents, it's a bone in your arm and it represents extension of a helping hand. So that was sort of one analogy that was used. The other was that our services radiate beyond the downtown core. And so, that was representative in the name Radius. The other piece is a lot of our clients, although we're not an Indigenous organization per se, a lot of the clients that we do serve do identify as having Indigenous background. And so there's a star blanket that is very representative of Indigenous heritage. And I think, the circle sort of represents the medicine wheel and that type of stuff. So when we think about Radius, you think about a circle, and then the little chevrons actually in our logo, we sort of we're trying to represent the star blanket in that without it being a star blanket, but doing a bit of a nod to sort of the Indigenous side of the work that we do, because that's part of, who we are and who we serve. So that's really the story, if there is one. Yeah.
No, that's amazing. I really love that story. I infer the like radiating past one type of health, let's say, and like growing and expanding in that way. And so that one was very evident to me, but I really love all those other reasons for the Radius choice. That's amazing. And so you mentioned in that though that it sounds to me like you might have been hired on during the pandemic. And
was
so
indeed.
Right. So my next question was about to be how that obviously Radius received some funding through the catch through PHAC as part of the CVP National Project Phase 1. I was wondering if you could tell us a bit about your efforts to encourage COVID-19 vaccine uptake in general as part of the project, but also if you wanted to describe what it was like coming into this role in the middle of a pandemic, please feel free to add that to the story as well.
Sure. Yes, you're right. So I joined the organization in December of 2020. So we were in the thick of it, really, at that point. And, if I can just touch on that for a few minutes, and then I can elaborate on the CVP National Project, I think, which was really important work, not only for us, but I think across the country. That work that happened was really valuable to the population. But for me personally, joining the organization, I think in the middle of the pandemic, there was pros and cons to that for sure. I think the big pro was I didn't know any different. So I didn't know what the organization looked like before I got here, before all of the change that happened as a result of the pandemic. You sort of learn as you go, what used to be, and then how we're doing it now, and then how are we going to do it when the pandemic is quote unquote over, if it's ever over. I know we know it's not over yet, but we're operating in a different state of that pandemic as well. So there was a lot of change in the organization as a result of that. The biggest one was we had to actually redeploy portions of our staff to operate an isolation facility for individuals experiencing homelessness. So in Edmonton, we were the lead for that, providing that. So, in the end, it started in a big kind of a warehouse conference area, and then it moved into a South End hotel. And so what we were doing was isolating individuals that were COVID positive or had COVID-like symptoms and required to legally isolate, but were experiencing homelessness because, of course, they have nowhere to isolate. So we operated that space and provided all the medical care and all that was needed, as long as they weren't sick enough to be hospitalized. Sick enough to hospitalize, they went to the hospital. We didn't do hospital level care. So we had to redeploy staff, including physicians, to do that work. And so that meant impact to our operations and operating hours and stuff like that. So that was a big impact, but I walked into that. So I didn't really know what the organization was like before that. So, that was challenging, of course, like any organization that was in the middle of the pandemic and responding to it from a health perspective, I think had big impact. So the CVP National Project piece came into play because of the work that we do and the partnerships that we have with our local health authority, Alberta Health Services. We have very good partnerships. We do have contracts with them for some of the services that we provide, because they recognize that without us, there's just more draw on the acute care system. So emergency rooms, more admissions, all that kind of stuff. They recognize that. And so they provide some funding to us to do some of the primary care work that we do to help keep individuals in primary care instead of in emergency and in acute care, right? So, and because of the nature of our approach, it's just very different than any other primary care clinic. It doesn't do things the way that we do it. So as a result of that, and already our work to respond to the pandemic, we were asked to be the lead organization in Edmonton to administer COVID-19 vaccines to the vulnerable population. So majority of them being homeless. And so we took that on, again, another thing added on to our workload in the middle of a pandemic, but also saw it as an absolutely necessary part of our work, and that nobody else could really undertake and be successful at in the way that we could. So we took that on. That started in March of 2021. So at the very end of March, we started our very first vaccine administration clinics. And that was for not only patients of our own clinic, but also patients that were just part of the community that weren't necessarily known to us. So we did this by outreach. So we would go out to community agencies like shelters or drop-ins, domestic abuse shelters, housing sites, so transitional housing sites that a lot of them had been set up as a result of the pandemic. So we went out to those sites. Community events, for example, we partnered with an organization that was running a pancake breakfast on Canada Day in 2021, and actually set up our mobile clinic, our little van, and did vaccines out of the van at a Canada Day breakfast. We went to, for example, there's a bank for individuals at Boyle Street Community Services that I mentioned before. They have a bank called Four Winds that they operate for when people receive their income support checks. So on check day, when folks were coming to get their money for check day, we would set up mobile clinics. It's sort of that you have a captive audience. We would set up clinics there, and as well doing it at our isolation facility for people that came in that were COVID positive, as well as doing it out of our clinic. So we also did it here. So we did it at all of those places, not all at the same time. We did outreach, of course. And so through that process, and then we started to get, potential information around the CVP National Project. Well, how can we bring in this to help make what we're already doing more successful? And I think, everybody experienced the drawbacks, or the pushback, I guess is a better word, from individuals not wanting COVID-19, all of the misinformation, all of the, the communications that were coming out and people being against it, and all that kind of stuff. So, we were battling that too. So what we, excuse me, I just need a quick drink. So the actual CVP National Project, what we did is we used that to fund the salary of a part-time, it was a full-time MOA for a contract period of time. So medical office assistant we hired in November of 2021. So we'd already been vaccinating, since really the beginning of April. And we hired someone dedicated specifically to the vaccine work. And so their role had a lot of different focuses, but their main focus was really to contact patients who were paneled to us, that we had contact information for, that hadn't received their first dose, and to talk to them about COVID-19 vaccine, to provide them education, to tell them that they could come here to get it, that we would even come pick them up with our outreach team and bring them here if they needed a ride, for example, or we would facilitate them getting the dose somewhere else if they wanted to go to a pharmacy or another site. And depending on their eligibility, of course, that all depended on the eligibility criteria. We couldn't just give it to everybody. So we had to follow the eligibility criteria like the rest of the country did, with age or, chronic conditions or whatever that people made them eligible at a given moment. So the other thing that she did is when we vaccinated patients or clients who were not our paneled patients prior to the vaccine outreach program, they got added to our electronic medical record. And so for any patients who'd received a first dose and were now due for a second dose, she would call them and tell them, now you're due for your second dose, we can make you an appointment, or you can come in on a walk-in basis, or we're going to be at X place doing an outreach clinic. You can go visit us there, just to encourage that. And again, I think the unique part of this was her ability to answer questions and not just talk about the appointment, right? So do you have questions about the vaccine? Do you have any concerns? What are those concerns? Providing that education and information. And that's why we chose an MOA instead of, just someone who could work a phone. We wanted someone with a little bit of health background so that they had a little bit of, understanding of what they were saying, versus just being able to read a script. The other thing is we, as part of her work and sort of connected to her work, we had also partnered with the government of Alberta, had put out a program, and I don't know if you remember this, is they put out a program where in a certain time period, if you received a dose of vaccine, you were eligible to receive a $100 gift card. So part of the challenge for many of our patients, they don't have mailing addresses. Where are they going to get these cards sent to? So we partnered with Government Alberta to be a distribution agent for the clients that had received and were eligible for that gift card and had received doses of vaccine from us. So if we had administered it and we provided them the list of all those people, they sent us those gift cards, and then we made contact with those individuals, or as they came into the clinic for other reasons to engage with us, we would give them their $100 gift card. So we were able to distribute, I can't even remember how many, it was quite a lot of $100 gift cards that people otherwise wouldn't have been able to get access to because they just had no way to be contacted, or they didn't have the means to be able to apply for it because it was an online type of thing that you had to apply for. So we helped them do that. The other piece is the Edmonton Community Foundation actually gave us a grant as well to give small gift cards to our clients as an incentive as they got vaccinated. And this was very early on. It was prior to the government program, the $100 gift cards. And so we were doing that. And so the MOA hired for that grant also helped manage the gift card program. So for each of our vaccine doses. So all of that wrapped together was kind of what the MOA focused on. And, unfortunately, we couldn't keep her for as long as we wanted to because the CVP money, of course, did eventually run out. But it was really helpful having someone dedicated to doing that work instead of on top of, somebody having to do all that work on the side of their desk. And frankly, it probably just wouldn't have gotten done in the way that it did without her. So that was great.
That's amazing. And it's all those little things that I think being in this job, other people wouldn't think about, that I can imagine someone hearing this incentive and then immediately saying, well, I'm not going to get vaccinated because I'm not going to get it. So it's the point of even going ahead. And because of the work that you were able to do with the MOA, it facilitated, I'm sure, so much and was so helpful to so many people. Hearing you list all those things, I can already think of many of the successes in the project and just overall in the work. I'd like to give you an opportunity in your own words to share some of the successes of the project, and as well some of the challenges too that must have come up during this time.
Yeah, of course. And as you said, there's many, and some of them are, inherent as I spoke, but I think some of them might be less obvious. And so, as I mentioned, we started vaccinating clients in March of 2021. And so up to then until June of 2022, when we haven't stopped doing vaccines, but it's certainly become more of a slow trickle. And so it was more of a dedicated focus up until the end of June. We provided over 4,200 doses of vaccine to vulnerable populations. So that's huge, and that's just in our city, right? In our little inner city population, that many doses. And I think the success is not only of just the number and the number of people we're able to help protect from COVID-19, but we built really valuable relationships with the external agencies that we hadn't previously had before as a result of our needing and wanting to do outreach. There were many agencies that were just begging us to come do an outreach clinic in their organization because they didn't have the capacity or authority to administer the vaccine to their clients. So that was really helpful. It connected us with clients that were previously unknown to us and that didn't know about us in terms of our services. So it actually added to our paneled patient list as well, because we found people who needed support who didn't know. Well, in some cases, they don't know or think that they need support until they know the support is there in a way that they feel comfortable accessing it. So that was also really helpful. We built on the trust relationships that we did already have. For some of the members of the community that had, were hesitant to receive the vaccine, if the organization where they might be housed or where they access services has a really good trusting relationship with them, and that organization is bringing us in to help them administer vaccine, that trust, there's a little bit of transfer of that trust. And so then the information that we would provide about the vaccine was more well received and more believed versus, us, being some overlord that's trying to, inject them with who knows, tracking devices or something. I don't know what the latest, what the worst messaging was that was out there, but there was some pretty wild stuff said about vaccines. So that was really helpful. And as I already mentioned, having that extra MOA as a dedicated resource was invaluable to having, it overall be success and our overall uptake to be increased. Yeah. Now, was there challenges? Of course there was. Weather is one of them. So if you want to set up an outreach clinic outside and it's pouring rain or it's 35 degrees, and Edmonton does get hot in the summer. And so, we had to contend with that sometimes if we were trying to do vaccine clinics outside. And that also changed the nature of, so if it was really nice outside, it was hard to find people at shelters and that kind of stuff, because if they can be outside, that's where they're going to be, right. So sometimes it was hard to get people congregating because in the summer months especially. Of course, the biggest challenge, like anyone else who was providing vaccine, is the misinformation. It was no different than the general public. I think if you look at the percentage of people in our population that were vaccine hesitant, it probably mirrored the general population, and maybe a little bit more so, because as I previously mentioned, a lot of our population were Indigenous, and I think we found the Indigenous population had a little bit greater sense of hesitancy as a result of history, right? So smallpox, for example, like there's a lot of Indigenous history that contributes to vaccine hesitancy generally, not just COVID-19 vaccine hesitancy. So we had a little bit of challenge with that. And, there was a few groups of community members that were very concerned and very vocal about it. And, they did their utmost to dissuade other community members from receiving vaccine. I think, the only other challenge that we have, and if you want to call it a challenge, is, we would have community members that took advantage, that weren't really vulnerable, but they took advantage of the fact that we were providing vaccine to vulnerable populations and tried to sort of skip lines and, that type of thing to get their vaccine administered here. And so, in the end, another person got vaccinated. And so we tried not to make too big of a deal about it without, opening our doors to the whole population kind of thing. And the only other thing is really because of the nature of the lifestyle of the population that we serve, is our inability to contact people for follow-up doses. People are experiencing homelessness. They don't have phones, they don't have an address for us to send reminders to and that type of stuff. So we had to rely on them and their encounters with us to, remind them about their next dose. So that was really one of the bigger challenges as well.
That makes sense. I mean, even working this job, I've seen, so many flyers in terms of getting vaccinated. It was every time I needed a dose, I was like, you could just walk down to this community health center in your own area. And I was like, that is for somebody else and different. And so, but at the same time, we are always, and we are still trying to encourage everybody to continue to get these doses. And so it's definitely difficult, but glad, despite all those challenges, obviously you guys were able to achieve so much amazing work, like you described. A crazy amazing amount of work in my opinion. And curious how since as you mentioned, the funding has been spent, how you've been able to still encourage the uptake of COVID-19 vaccines since the ending of the project.
Right. So as I'd mentioned, it was a bigger focus for up until past the last summer, but we still do have access to the vaccine here. So we still do have it. And if clients are due, we will offer it. And so because our clinic actually has a full spectrum of vaccines available here, it's a regular part of our conversations when clients visit. So there's some vaccines like yellow fever and, stuff like that we don't do here, but we do every other possible vaccine because we have the authority granted to us from the local health authority to be able to do that. So it's part of our regular routine visits that if somebody, it'll pop up as a reminder that your next dose is due. And so when they come in to see their primary care provider, we'll remind them. We're not making intentional phone calls anymore. Frankly, we just don't have the resources to be able to do that type of work. But we are reminding folks as they come in to see us. We do have signs in the clinic as well that we're offering vaccine, because we also, as I mentioned, have our supervised consumption site. So sometimes people just come into the building just to use the supervised consumption site. And so those encounters are a little bit different. And so, folks can still be reminded about their vaccine there. And the other thing is just having staff provide the education if they notice that someone hasn't had any doses, or unless they've, specifically documented, like, stop talking to me about COVID-19, because we do get that. People are just, I don't want it, and I don't want you to keep telling me about it because it just makes me mad. We do have those conversations, and, that's fair. And so, but really, we've just tried to encourage that through our regular processes. It's just integrated into what we do and how our other vaccines are administered as well.
That makes sense. Perfect. What health and support needs do you see within the community and among the clients that Radius Community Health and Healing serves that could be met through further investment and support from both the provincial and federal governments?
That is a $1 million question. Maybe more than $1 million.
I was going to say, I think at this rate, multiple millions, according to every answer I've gotten.
Yeah. I think, to be honest, Hillary, I think we could do a podcast about just that question. I honestly don't know where to begin with this response. And I, as I'd mentioned earlier, when you talk about the social determinants of health, let's tackle those. And I know it's a really complex problem. I was previously part of Alberta put together a task force on homelessness, and I was part of that task force. And I think there's so many issues that are wrapped into homelessness and poverty and severe mental health conditions, addictions, and mental health, all of those things. It's a really complex problem, but we gotta parse it out and piece it apart, take it apart to really tackle it. Because I often use the analogy of boiling the ocean, or biting the whole elephant instead of just one piece of them. And so I think we have to try and find the pieces that we can make an impact on. But, the health needs of this population are so great. Some people think that, if we just had more housing, that all of this would go away. I do think we do need more housing. I think part of our issue is that we need a bigger spectrum of housing. So do we need more supportive housing? Yes, 110%. We need more supportive housing, but we also need other housing that's on a different spectrum, or across the spectrum, if you will. So we also need more affordable housing. Some people are really capable of living independently. They just can't afford to live independently because of the cost of renting an apartment or purchasing a home. They just don't have the capacity to be able to do that. And then there's all the people that are in between supportive and just affordable. And I like to call it supported housing. So, we talk about getting people housed, but really what we need is to get people housed and then surround them with the supports that make sense for that individual to help them stay housed. And that might mean, regular visits for mental health supports. It might mean regular visits for wound care, or, from home care for injections for their diabetes, or whatever it might mean. And I think that's, it's difficult to design a system that's got unique supports for individuals. So that's really what we need. Housing will help. For sure. Income, our income support program is, I think certainly tackles part of what folks need for supports. But, I think when you think about the shelter allowance that folks get on income support, it's under $400. There's nowhere you can rent that's going to cost you that little amount. And so, we end up perpetuating homelessness because folks just can't afford to stay housed. Mental health supports, I think this is a really, really big one. When we talk about our public healthcare system, it's all a lot of physical health things that you can go to the hospital or go to a doctor and get supports for, where there's no cost attached to it. But I don't know of anywhere other than here where you can go see a psychologist and not have to pay for it. And the population that we serve has so much trauma in their histories. I don't know what, Hillary, if you've done any work or any looking into the adverse childhood experiences surveys and that type of thing. And so we base a lot of our work on that premise. And so we almost make assumptions that people have high ACE scores and that their trauma background is significant. And we actually did do that. We did a survey a few years ago. General population, when you do an ACE survey with general population, an ACE score of 4 or higher is considered significant, considered to have an impact on your development and on your development of other health conditions as you age. And general population, about 12% of the population has an ACE score of 4 or higher. When we did a survey of Boyle McCauley Health Centre clients, at the time it was Boyle McCauley Health Centre clients, when we did our survey, 93% of our patients have an ACE score of 4 or higher, and more than half had an ACE score of 10 out of 10. And so that's a lot of trauma to deal with. And so psychology is really what they need. They need help dealing with the trauma. And so for me, that is like, if I could put a gold star on that thing, is we need public access to mental health supports. That's the biggest one. And the other thing is detox and addictions treatments. There just isn't enough. There just isn't. People are turned away daily. And, if you're really feeling like you're ready to, seek treatment, and you walk up to detox and say, sorry, we're full again for the 5th day in a row, it gets pretty demoralizing. And after a while, you stop trying, right? And that isn't what we want. So I think those are the big things for me.
Absolutely. Actually, funnily enough, to answer your question, the last episode that we just aired is about something that's very similar to, that uses something similar to ACE. It's called the Attached Parenting Program. It's with Nicole Letourneau, who is a professor at U Calgary, who partnered with CUPS. And the way that they try to teach parenting is through this program. And after the episode, I've taken the ACE test and have a higher score than 4, for being completely honest, which is probably why I have this job. And we had a whole conversation about the importance of that and how that does feed into these wraparound care supports, how one domino tile really does affect all of the others, and how in my own life, one thing could have maybe put me into part of this homelessness
100%.
crisis or precariously housed. And so this question always, as you said, it's always the multi-million-dollar question, because I always feel all of the answers are very real and very valid. So there's never enough money to grow these programs and grow the supports, because it can be anybody. It is a lot of people right now across the entire country, which is why every community health center gets asked that question, because we just need further investment. Is basically what everyone's crying for, right?
I have 2 FTE worth of psychologists, and they are busy nonstop. I could probably have 5 more, and they'd be busy.
Absolutely.
I don't have the funding.
Wow. And we keep hoping. We do keep hoping and advocating. Absolutely. I want to thank you so much for taking the time to speak with us today about Radius. I'm so excited about the name change and everything that you guys are doing. And if anyone wanted to learn more about Radius Community Health and Healing and the work that you're doing over there, where would they go?
They would go to radiushealth.ca. So that's our new website, and some of it is still under construction, admittedly, but the best part is that it does have links to our previous website as Boyle McCauley Health Centre. And so a lot of that information is very similar. We're just refreshing the look of the pages and stuff. But in terms of our programming and the services we offer, none of that has really changed from the old website. So it's radiushealth.ca is the new website, and bmhc.net is the old website, but there's links to the old site at the new site. And hopefully soon the new site will be fully operational and we will decommission the old one. So
absolutely. I did notice that in my research. So good to know that eventually there will be that fusion. But amazing, wonderful episode. Thank you so much again for taking the time to speak with me today, Tricia.
Thanks so much for having me.
Thank you for listening to Community Matters, a podcast from the Canadian Association of Community Health Centres. To learn more about our association and the important work of community health centres across Canada, go to www.cachc.ca.